Greetings and good afternoon, everybody. I want to welcome you to UCSF Family and Community Medicine Grand Rounds. We have a terrific session today that I'm really excited about, but just a few housekeeping reminders first. Just to let you know, this session, like all other round round sessions, is being recorded. If you want to watch today's session again or other sessions that you might have missed, they're posted on the UCSF Family and Community Medicine website, and they're on YouTube. You can watch them there. And we hope you'll look at the other ones as well that you might have missed. If you have ideas for other Grand Round topics that you'd be interested in sharing or speakers you'd like to suggest, please email me directly. My name is Dr. Margot Benner. I'm in the Department of Family Medicine. And also today we'll be sending out an evaluation in the chat that you can fill out with suggestions for our speakers, or you can also put in suggestions for other Grand Round topics or speakers. Before we go ahead and get started, I want to give a special thanks to our fantastic team that makes Grand Rounds possible. We have Roy, we have Ben, and Erigo, who are our terrific IT team, and Roy Johnston, who's in family medicine, helping keep our organization running for Grand Rounds. Much appreciated. And I also wanted just a quick reminder for everybody who is waiting to find out when when the RONeil Colloquium is, that will be May 25th this year at Mission Bay and in person, which we're very excited about. So we hope that we will see you there in person or remotely. We have both options for this year. So on to Grand Rounds today. The session for today is called the National Clinician Consultation Center, 30 years and still counting, of tele-consultation for provider capacity building and public health service. We have fantastic presenters today who will be talking about the NCCC, which is a unique federally supported educational resource of the Ryan White HIV/AIDS program, which has been continually adapted since the early 1990s to address the evolving healthcare needs of HIV-affected communities. The NCCC team has provided over 300,000 consultations to clinicians across the US, and it's contributed to the growth and development of several notable initiatives, including an international community dedicated to the intersection of reproductive health and infectious diseases, as well as multidisciplinary educational collaborations across medicine, nursing, and pharmacy. Today's presentation is going to include a brief history of the NCCC, recent and in future expansion highlights, and most importantly, the perspectives of several of our key team members. So who are those team members? So they asked to introduce themselves, but I just have to share the highlights anyway. We have with us today Dr. Ron Goldschmidt, who's a family community medicine professor and vice chair. He's a seasoned family doctor who founded the NCCC. Also, we have Brenda Goldhammer. She's the program director. She's worked in the HIV, viral hepatitis, and substance use field for over 30 years, and she serves as the NCCC program director. Dr. Becky Dong is with us. Betty is a professor of clinical pharmacy and family medicine. She's a senior HIV and viral hepatitis consultant with the NCCC. We also have Dr. Christine Pecci, who's a professor of family and community medicine and the NCCC Women and Children's Health Consultant. Christine is a family physician and a clinician educator with a lot of maternal health expertise. She provides consultation on perinatal HIV. And we also have Dr. Carolyn Hsu, who is a family physician and HIV specialist. So I'm looking forward to today's presentation. As always, we are excited to hear your comments and questions. The presenters are eager to hear your thoughts. Please enter your questions, just type them into the Q&A for us, and we will either answer them live or respond to them. And I'm looking forward to the presentation. So thank you to all of our presenters.
Great. Thank you so much, Margot, for the very, very kind words and warm welcome. And Brenda, thanks for running our slides for us this afternoon. So again, just really thankful and appreciative to the Grand Rounds organizers for allowing us to share information on this special April Fool's Day with the team, and also really lovely to see some familiar names as well in the participants. You can go ahead and advance to the next slide, please. Okay, great. So just to recap, these are the folks that we were able to grab to share some information in their stories with us. We actually have a fairly sizable team. You'll hear a little bit later on, sort of the roles that we have within our program, but we just thought it might be nice to, share several perspectives. And everyone will be introducing themselves. Thanks. Next. So just want to step back and share that, we had started or, done another round of our strategic planning, which we were overdue for. And so this is where we are as far as the vision and how we see ourselves in this community that we're trying to serve and support. Next slide. Great. So I'm going to turn it over to Ron. No one better than Ron to start us off with sharing more information about the history of the NCCC.
There we go. Thank you very much. I'm glad you didn't introduce me as the biggest fool on April Fool's Day. But maybe that is the case. Who knows? I am glad to tell the story of the NCCC and the history of it. In fact, this is really the story of the NCCC is very much a story about family medicine, specifically about family medicine residency program at San Francisco General Hospital itself, and the department. And so the timeline runs a little bit like this. The department was started in 1972. I joined in 1973 in the residency program. And in 1979, we did something that was really, really radical. It doesn't seem radical at the time, but I mean, now it doesn't seem radical, but at the time it really was radical. It was starting a family medicine inpatient service. And so while we were navigating all the hospital and departmental and other speed bumps and challenges that came our way, something was happening right under our noses that we didn't recognize. And by 1981, we started seeing some unusual cases that were occurring in gay men, which were Kaposi sarcoma and opportunistic infections, and specifically lots and lots of pneumonia. And we didn't understand what was going on. And then in 1981, next slide, please, it all got explained to us. This is a famous report in the Morbidity Mortality Weekly Report from the CDC, identifying 5 cases of pneumocystis pneumonia in Los Angeles. And these were all in young gay men. And so they identified that something was happening. And sure enough, it fit exactly with our experience on our family medicine inpatient service. We had had a number of patients with pneumonia that were similar, that were not clearly bacterial, not clearly viral. We just didn't know what they were. So right under our noses, an epidemic was happening on our brand new family medicine inpatient service. Next slide, please. So what happened is our faculty and our residents really became world experts very quickly. We became experts in all those diseases that we were talking about. And this is at a time when we really didn't know what AIDS was, what HIV was, had all kinds of different names. And it was quite a mystery, and it was very, very scary. I have to say that the nurses at San Francisco General Hospital were clear leaders in this area, as were the social workers, and then all the physicians as well, who participated in care for these patients. And along with the community, the geographic community of San Francisco, we were all a community at war with the disease. And we didn't really know what it was, but we knew that it was war, and we were in for it, and we were trying to meet the challenge. And as it turns out, this new disease probably dominated in terms of the types of cases we had. It dominated the next couple of decades on the family medicine inpatient service, so much so that we became experts. And next slide, please. No bigger expert at all than this is Becky Dong. She was our first family medicine inpatient service pharmacist, and our first NCCC pharmacist as well. Betty did something that is kind of unheralded, which is she kept us out of trouble. She managed to help us avoid toxicity from really toxic medicines, really toxic drug interactions, and all kinds of problems that we were not expecting. And so a lot of our success was very much due to Betty and her critically helpful participation. Next slide. So then in 1988, Health Resources and Services Administration, called HRSA, developed what's called the AIDS Education and Training Centers program to educate the country's clinicians about HIV. And one of the 4 centers was the Western AIDS ETC, which is Northern California. And we were selected as the San Francisco site for training and education on HIV. And then in 1991, we found that really we were being asked to do a lot of questions and answers about how to manage clinical care locally. And so we suggested the idea of a warm line to the feds, who didn't particularly go for it, but we also suggested it to the American Academy of Family Physicians. And they were spectacularly supportive of doing something for HIV, or at the time called AIDS, and gave us a $20,000 grant for a national warm line for clinical advice to family physicians nationally. And they were really supportive for a period of about 10 years to the tune of about $270,000. Without them, we may not have gotten a really good start. By 1993, HRSA thought that it was a good idea what we were doing, and they awarded us a telephone consultation service for advice to clinicians. And again, as I mentioned before, most of the advice we were giving early on was for opportunistic infections, and then later on, antiretrovirals became the key thing. Next slide, please. During the 1990s, we had a couple of illustrious visitors. On the left, you'll see me with Kirsten Bolano, one of our outstanding clinical pharmacists, and Alex Moy, a family physician, meeting with Christine Gebbe, who had the title, believe it or not, of the AIDS Czar, something that would not go over well these days, I don't think. At any rate, she came to visit because it's part of what an AIDS czar apparently does. And then a year later, we were visited by Nancy Pelosi, who was Representative Pelosi from San Francisco, who is talking with Jill Legg on her left there, myself, and then some unknown characters in the background there. So she visited, and she liked very much what we were doing as well. Representative Pelosi became very important later on. Next slide, please. In 1997, there was a landmark article by Denise Cardone in the New England Journal. She was from the CDC, and her article showed that post-exposure prophylaxis for occupational exposures worked. So Julie Gerberding, who was an infectious disease person here at San Francisco General, was really the national expert on post-exposure prophylaxis at the time. And she was getting all kinds of calls at all kinds of hours with questions about how to do post-exposure prophylaxis. She couldn't meet the demand. And one day we met each other in the cafeteria, and we started talking, and we hatched the idea of a national PEP line, either by the CDC or by HRSA. I convinced her that HRSA would be the better way to go, and so together we put together a proposal, and within a few months there was a meeting on Ward 83 of the experts from CDC, HRSA, NIH, and other experts from around the country about whether there should be a national PEP line for occupational exposures. And so that, to make a long story short, that materialized shortly thereafter. Next slide. So Representative Pelosi in 1999, on my birthday, no less, was able to do something. At the time, the government was in gridlock. It was in even greater gridlock than we are experiencing today. And so I'm not exactly sure how she was able to do so, but she had the ability to create a funding source for us. Next slide, please. So with a simple, not so simple, letter to Joe ONeil of HRSA, the Associate Administrator of HRSA, she created the National Clinician Consultation Center with funding of $1,500,000 for the purposes of a warm line and a PEP line. And so really Nancy Pelosi is the one who created the congressional authorization for the program that we have right now, above and beyond the work of the AIDS education and training centers. Next slide, please. Subsequently, there had been the landmark study, the 1994 AIDS Clinical Trials Group Study 076, that showed that giving antiretrovirals to pregnant mothers and during delivery and to their infants, decreased transmission enormously. And so eventually we were able to find a funding source in HRSA and create a perinatal HIV hotline in 2004. With the information of PrEP being effective, based in large part on a study, again, at San Francisco General Hospital by Bob Grant, we were able to talk to CDC and HRSA into supporting a PrEP line in 2014. And then to make the family medicine story come full circle, the HRSA Bureau of Primary Health Care, called BPHC, was at the time headed by someone who was a graduate of the family medicine residency program, Arthur or Seiji Hayashi was his name. And he and I had been in discussions about a number of things. And whenever I went to HRSA, I would go meet with him. And so we were on very good terms, and he knew completely what we did on the NCCC. And then he gave me a call one day and said, you know, substance use is really going to become big. And I think you should do a substance use swarm line. I said, that's crazy. We do HIV. And he said, it's not crazy, and we'll see if we can find funding for it. So again, to make a long story short, through his spectacular help, we were able to get Bureau of Primary Health Care to put money into the HRSA HIV Bureau to support our substance use warm line out of the NCCC. And so that is a nice, tidy story of family medicine's contribution to, I think, the only national service that is run by family physicians that provides face-to-face care, not face-to-face, but personal advice to family physicians and all clinicians in the country. So with that, I will end.
Thank you so much, Ron. I feel like I've heard you share this story, you know, at different times, and it never fails to amaze me. I think Ron is extraordinarily humble and didn't sort of add the footnote that we've been a continuously federally funded program really since we got on to HRSA's radar. And I think that is no small task. So next slide, please. So for this next section, you know, after sort of hearing the story about where we've been, I think, you know, for our program, it's really meant a lot in terms of where we are and where we want to go in the future. So as I mentioned earlier, you know, we're just, we were able to pull in a few team members to co-present today, but really at this point, given the growth of our services and the nature of the different consultation lines we have, as you can imagine, our clinical team had to also scale up to address just the many, many calls that were coming through over the years. And so we hear that it's really nice to sometimes see faces so that people know who they speak with when they call our numbers. So this is a current amalgamation of who's on our clinical team. And I see that a few of you are on and listening. So appreciate you being here. And I also just wanted to draw just a quick note to our current and new clinical director, Dr. Chris Bositis, who is actually based in Massachusetts currently, but will be transitioning out. And I think Chris is a very, very seasoned HIV expert in his own right and Hep C experience. So we are just very fortunate that he's joined our team and is playing such a vital role to support the clinical growth that we've experienced in the years ahead. And you'll be hearing a little bit more from Betty and Christine as well. Next slide. The other part to potentially just note is that because we are taking so many calls and a number of them are quite complex in nature, we felt like it was really important to build up sort of a multiple levels of support. So not only are we taking questions from callers, but our team runs into our own questions, and so we have been very, very fortunate at being able to enlist the support of sort of super specialists. A few of you might recognize some of the folks that are actually here at UC. So Michelle Tana and Ted Rule are in the departments of GI and Peds. And so they really are there to kind of be our backup and to help us think through really complex challenges or emerging topics. Christine might go through a little bit later when she talks about our women and children's health portfolio. But breastfeeding and HIV, for example, is a really, really hot topic right now. And I think because there's not a lot of, at least US-based data or experience to guide us through, it really helps to be able to tap on some folks who can help us identify where we want to go as consultants. Next slide. The other part that I'm really super happy to be able to at least share some faces on is that, you know, our administrative team has also grown, and we're starting to catch up a little bit in terms of being able to staff up. But I think we really could not do all the work that we do without every single person listed here. You'll hear a little bit from Brenda as our project director, but we're also really pleased to welcome Wasu as well as the program manager. This was Brenda's former position as she stepped up to take on the director reins. Next slide. So people by now are hopefully wondering how many calls we've gotten. And so I wasn't able to recreate the same map because we didn't have access to the same software. But back in 2009, this was just a snapshot of about, I think it was around 12,000 calls for that year. And fast forward to now, when we were looking at our last cumulative 4-year report to funders, we were about at 57,000 calls for that 4-year period. And so we've definitely grown. Hence the staffing models that we've created at this point. And pre-COVID, we were actually operating out of the call center at the General. So that picture on the lower right-hand corner there is just day in the office with the NCCC. All of our calls are free, actually, because we're federally supported. It was really important for us to be able to be accessible to everyone, every provider, no matter what their practice setting was, no matter what their professional experience was. We felt that was, and continue to feel that is extraordinarily important, especially now as we're grappling with a lot of really important issues with health disparities. Next slide. So I'm going to just sort of start my wrap up, but we also as a program want to make sure that we are always doing the best that we can. So our callers, if they are able to provide an email address to us, we routinely send out caller surveys. And so this goes into just our larger evaluation framework so that we can make sure that we are being responsive to the needs of our callers, but also that we are able to meet our deliverables with our federal sponsors. So I just pulled a couple of quotes, and hopefully they'll sort of highlight the role and the support that we're able to provide for callers. I will also make a note that this is completely bidirectional. I think we would not be the program that we are today without having callers share their experience and share their cases. I think we really do try to support a culture of continuous learning, continuous teaching, and we learn from every single one of our calls. The other thing maybe to note that could be of interest is that historically we've been really staffing by providers who are sort of immediately available and living in the Bay Area. But really, I think one of the sort of silver linings to emerge from COVID is that we were able to onboard folks who are outside of the Bay Area. And I think this is really going to be important for us because especially with HIV care, sometimes we forget that we're sort of in a bubble in some ways in San Francisco. And so, what providers do in San Francisco may look a little bit different from what folks are doing elsewhere. Next slide. This I just wanted to sort of, mention that folks could probably imagine that at this point we're sitting on a lot of information in terms of just our call data. And so I think, as our program is sort of thinking through how can we flex our evaluation muscles and just really figure out, are we doing what we want to do? Are we tracking to the needs that are sort of evolving in terms of where HIV care is going? I think we've been trying to figure out like how can we get in data that's really going to inform some of these more specific questions. And so, one of the discussions we've been having is sort of like trying to match our call volume to the, the epidemiology of HIV in the country. And so you can just sort of see here that the sort of yellowish or peach bubbles are where we have been getting more call volume from. And I think this is really reflecting sort of the previous epidemiology of HIV, but folks here are probably aware that there's need in the southern states as well in the Southeast. Next slide. So a couple of new collaborations and partnerships that I just really wanted to, or that we wanted to share with everyone today was a couple initiatives. So as Ron mentioned, the National Substance Use Worm Line was started in 2015, but a couple of years ago, actually, the state approached us and also California Poison Control to see if we would be able to sort of combine forces to offer 24/7 support focused on substance use disorder care for any caller in California. So there's been a lot of investment in the state to really sort of, make treatment accessible no matter, what type of healthcare setting a patient's arriving in, whether it's the emergency room, hospitals, community health centers. And so we already had a very established infrastructure, as did Poison Control, to be able to take calls from providers. And we were both free services. So from that idea, really, the California Substance Use Line was created. That's our number there. It's my shameless plug for folks to save it to their phones. But we have really, I think this partnership has meant a lot to us in terms of being able to, work with an amazing team at Poison Control and to really, make sure that we're stepping forward to do what we can to help with the substance use disorder needs across the state of California. One of the other neat things that we've also been trying to sort of stretch our muscles in is collaborating with some of the more research-oriented programs, I would say, that are run out of UC. So this is just one example down there, the UCSF SeroPrep study. We are very fortunate to have supportive folks at the CDC, so they also plug us in some of the updated guidelines. But if you go to the next slide, the SeroPrep study has been running out of UC for a number of years. It's changed hands, so now Monica Gandhi and Kate Koss are leading it, but I think it was started by Bob Grant. But this is a really interesting research project. So I think anyone here who is offering PrEP may want to just flag this website. But what the SeroPrep team is trying to do is really understand, if patients acquire HIV in the setting of regular PrEP use, why is that? I think there are a number of sort of unanswered questions still around why that might be, even though cases are very, very infrequent. The other thing that is getting huge interest is that some folks have sort of unusual or unanticipated HIV screening and testing results. And again, in the context of PrEP use, we just have a lot to learn, I think, around that issue. And so CDC approached us because they knew that we were getting calls about PrEP, including unusual testing questions. And so really, it felt like a natural collaboration to be able to work more closely with Kate and Monica from the SeroPrep team. So as it is now, the PrEP guidelines mention that if a caller, any caller in the US has a case that they think might sort of fit into this scenario, that they would call us and we would reach out and coordinate with the SeroPrep team. Next slide. Some other things, and I think Brenda's going to highlight more about sort of where we've been trying to grow our technology legs, is just really trying to get the word out there about who we are and what we do. So this is a new app that the AETC program developed within the last 2 years or so, and so we are included as a resource. HIV Assist is also a really neat sort of online tool that if folks go to their website, basically you sort of plug in some case characteristics, and then it will, behind a very, very complicated and elegant algorithm, it'll sort of output what some appropriate evidence-based ART options might be for a patient. And if you go to the next slide, they also include us, as I mentioned. So for very, very challenging cases where there might be limited options for treatment, they encourage folks to reach out to us. Next slide. And because we also want to be good citizens of the UC and other regional sort of educational program worlds, we have gotten an increasing number of requests to sort of almost serve as an elective site or rotation site for learners that are not interested not only in HIV, but also Hep C and addiction. And as Brenda mentioned earlier, or sorry, Margo, when she introduced us, we have been running the Repro ID listserv for a number of years now. And so it's a very, very dynamic forum for people to post questions that are of interest, either sort of clinical care or also just emerging research issues. The next slide. And then before I turn it over to Brenda, I just wanted to share we were able to very lucky to get some supplemental funding from HRSA to sort of go in a slightly different direction beyond just taking calls. So we are trying to build out a PrEP training preceptorship. So really working with a wonderful team of our PrEP consultants and some other folks within the UC learning programs to be able to develop just, hopefully very, very user-friendly modules to be able to then work off of for more intensive sort of PrEP bootcamp type experiences. Brenda, I think this is you.
There we go. Hi, I'm Brenda Goldhammer. As Carolyn and Margot mentioned, I'm the program director for the National Clinician Consultation Center. When I first joined the center in 2012, one of the first tasks that was put in front of me was actually to do some infrastructure projects. We were very fortunate to have received some one-time funding from HRSA to really think about how we can sort of improve our operations. And one of the first areas that we really had considered for improvement was our database. We were utilizing a database that really required that our staff were always on site. Only selected computers could have the database loaded into it. And this was for collecting information from our callers, everything from their contact information to the facilities they work out of, and of course, the clinical features of the call. And so we brought on an IT strategist to really help us think through really what would be a database that could potentially grow with us. And he quickly directed us towards a customer relationship management system. I was really fortunate to have been coming from a project that had just implemented Salesforce and was effectively using it as an EMR. And so this became kind of a natural progression for us once we landed on Salesforce. Salesforce has a very close relationship with UCSF. In fact, if you're not aware, Salesforce has been donated by Mark Benioff as a platform that any of us can utilize. And so for us, Salesforce really checked off all the boxes of what we really needed. Of import, as Carolyn mentioned, we're bi-directional. We want our team, of consultants to have to work with a system that was really easy to use, that was user-friendly. And then for our callers, we wanted something that ultimately made it very easy for us to be able to identify who they are, what they've even contacted us about in the past, so we could pull up their previous cases or cases that maybe they even wanted to build upon. And so the build of Salesforce was pretty incredible. We brought in a product manager that really was the liaison between us and a third-party vendor to help us with this build. For us, the build didn't just include putting together, registration forms in terms of contact information and facility information, but we also needed to create very distinct forms for our different clinical services at that time. And for us, Salesforce has been this longstanding relationship since 2013. Not only are we working with their platform, but UCSF has an amazing Salesforce support team. And we actually directly are connected with Salesforce. We meet on a regular basis, on a monthly basis with Salesforce, really to present them with our business case problems. And for Salesforce to really help us think about what might be some good solutions that are available to us through Salesforce. So this has really been like the gift that keeps on giving. So in terms of how we continue to improve upon how our database, and this is, I think, one of the main selling points that Salesforce had for us is it's so agile. We've incorporated the plan, do, check, act model for all of our continuous quality improvement. And this really allows for us to improve upon the forms that we've already created and improve upon the workflows. And more importantly, it also allows for us with Salesforce develops new features. It allows for us to really think about how these new features may be helpful for us in our collection of information that we maintain in our database, and as well as Salesforce improvements around analytics as well. So we are using a lot more analytical features of Salesforce now, even than we did when we first started using Salesforce. So in terms of our future roadmap, now that we have Salesforce in place, one of the first things that we have been, that we started to build and continue to work on is a web-based portal. This allows for outside users to be able to submit cases directly into our Salesforce database. So it's already documented there. We're able to review the features, the clinical features of those cases, contact that user, and then provide them that consultation. So really seamless and really nice for clinicians who are extremely busy and maybe are thinking of a question as they're working through their case notes at the end of the day, and they can just throw in a question into the web portal, and then we're able to contact them at a time that's convenient for them during our hours of operation, so that we can provide them clinical advice in a timely fashion. The new directions that we're moving into right now as we speak, first is telephony. This is allows for us to integrate our telephone into Salesforce itself. And in effect, our computers are acting very much like Zoom, like a voice over IP, in which callers, when they contact us, those calls will go directly through to Salesforce, into Salesforce, and then pop up for us. And so this will allow for a lot of flexibility for us to sort of know who's calling us. And we can also see any past reasons they've contacted us before. Really improves our productivity. We're currently also looking at Salesforce chatbots, and we're in the process of putting those together. This will allow for us to build in some algorithms through our chat that hopefully can even resolve some case scenarios. And then the other piece that we're looking into incorporating is Salesforce survey. So all of this would live in Salesforce, which is pretty amazing. So a little bit more about telephony. This is, as I mentioned, this is just allows for when a caller contacts us, it goes through this CTI server that directs directly into our Salesforce, and then we are able to pick up that call. I think what makes it so incredible is, one, it brings up this pop window for us. We know who's contacting us. If the phone number is recognized, it brings up their contact records. So we're able to, politely answer the call, knowing who it is. And then if we need to call that caller back, it also allows for us to just click to call directly from our computers, which is pretty exciting. And so we're in the process right now of solidifying our vendor selection. As you can probably imagine, some of the IT security review processes have been pretty long and a bit arduous, but also really necessary to ensure that, of course, all of our contact information is kept safely. And then in terms of chat, HRSA, our funder, has challenged us to really think about how we can expand upon the channels in which our users utilize our services. And so chat is really the next phase for us. This will allow for anyone to come to our website. They can, certainly look up any sort of they can ask us any type of operational questions, like when are you open? Who answers your telephone calls? Is there a cost for what you do? It also will allow for us to create some sort of standardized messaging around some of the frequently asked questions that we anticipate receiving through the chat. This is really, we're hoping that this chat will be appealing to more users. I think we're recognizing, while we've been old school and been relying on old school landlines for many, many years, people are engaging with technology really differently, and clinicians are really seeking healthcare information in a different way, particularly because everyone's got a computer in their pants pockets at all time. And so we're hoping that chat really is just hits the nail on the head in terms of being another feature that we offer that brings in a new audience, helps us continue to build our relationship between us and our users. And ultimately improves efficiency. Chat not only will live on our website, but also as people potentially create cases through chat, that information can be funneled directly into Salesforce and populate into our Salesforce case forms. And so we're still continuing to collect that important data at all times. So we thought, now that we talked a little bit about our past, our present, and our future, I'm really thrilled to be introducing our next two speakers. I think we've spoken a little bit about both Dr. Becky Dong and Dr. Christine Pecci. We've invited them to really come participate and reflect on sort of their experience and history with us. So our first speaker is going to be Dr. Becky Dong.
Hi, thank you, Brenda. So I am Becky Dong, and I am one of the 3 pharmacists working at the triple NCC. The other 2 are Christina Gruda and Padia Sabari. So you can see that I'm actually doing this presentation from the NCCC. So one of the things that I'm always asked as a pharmacist is, how did I actually get a job here at the NCCC? And I think Ron went over this a little bit, but I was the pharmacist on the first family practice inpatient service here at the General during the height of the HIV epidemic. It was there that I worked with some amazing physicians and family practitioners and learned about HIV and their care. And I was so awed by the care there that when Ron asked me to join him as part of the warm line, as the director of drug information, I jumped at the chance and I have never looked back. And I really thought that was an amazing experience and still is. So I was really delighted to join the NCC. So I have been consulting for the NCC since I started. Some very, very long time ago. And I've had a lot of experiences. So right now I actually consult for all the different lines except for substance abuse, because I have more clinical experience with all the other warm line and post-exposure and hepatitis C lines. I also do, with an ID physician that's on our team, HIV and Hep C consultations for pharmacists that care for incarcerated HIV and Hep C persons in the Federal Bureau of Prisons. And we do this on a monthly basis. And it's quite interesting. And there are some different aspects and perspectives that you don't think about when you're caring for persons that are incarcerated. So one of the things, if you've never called our service, you might want to do that, because from my perspective, taking calls is quite fascinating. It's interesting. Some of the calls are quite unexpected. You get a bird's eye view of what HIV care is across the United States compared to here in California. We get calls from all disciplines, pharmacists, nurse practitioners, people who have gotten needle sticks. And I've actually taken a lot of calls from previous family practice residents. It's always nice to say hello. So one of the things that we as clinicians do is, of course, we answer the question for the call, but we also try to teach at the same time. So we're always looking and focusing on the question behind the question. That is, those questions that may not have been asked. For instance, for a lot of our calls now, we're getting questions about antiretroviral simplification, going from older regimens down to newer, more streamlined, more potent regimens. So besides just giving them options for the provider to pick the antiretroviral regimen, we will also go through the drug medication list to make sure there's no drug interactions, talk about adherence issues, discuss any drug interactions, our startup side effects, and also make sure that we talk about any effects that may occur if anybody has any hepatitis B or Hep C, or any renal or hepatic dysfunction, or if they're pregnant. So we want to teach that into our consultations. A lot of our callers may not have a question, they just want us to validate or provide alternative recommendations for what their plan is. And it's nice to be able to discuss that with sort of very non-judgmental colleagues that have the same goal of improving HIV care. So we do get a lot of questions about drug interactions, adherence, drug toxicities, et cetera. And I always find that our callers are very grateful to have the opportunity just to bounce off their thoughts with us. The NCCC has also been a training and educational site for many different types of healthcare professionals. Since 1993, the NCC has actually funded 1-year HIV training for 11 second-year pharmacy residents who are interested in HIV careers. The majority of them are now HIV employed. As you've heard, we also provide a lot of training opportunities pharmacy residents, nurse practitioner students, and visiting family practice and other MDs from the United States. And we've also had international attendees. So one of the things that I wanted to reflect upon was, what was it like all these years working at the NCCC? Well, one of the things is that there is a focus on lifelong learning. We have a very supportive leadership, and we have lots of consultants to expand clinical expertise and maintain the most up-to-date database for our callers. What is really nice with our triple C group is that we're multidisciplinary. We deliver team-based care. We have nurse practitioners, ID physicians, family practice physicians, clinical pharmacists, and we all really respect each other. We value our own skills as well as other skills, and we do not actually forget to consult with each other. So it's really nice that if you're working on a call that tends to be very complex and sometimes out of my expertise, like if there's asking about an extensive diagnosis, I can churn or consult with my ID physician or my family practice physician to get more information about presenting that call. I think the NCCC allows pharmacists to practice at the top of their profession, and we always feel appreciated across the United States. We're actually a very fun group. And when we were all in the office, we used to have food all the time. You could not come into the office without having some kind of food. There would be bakers, chocolate cakes, we would have cheese day. At least now that we're all working, a lot of us are working off-site, weight gain is no longer an issue. So I think that I'm just gonna stop here and just reflect on the fact that it's been a wonderful life here for me at the NCCC, and I don't plan to leave unless I get so demented that I can't actually consult anymore. So with that, I want to thank them for letting me provide some reflections. This was not a paid advertisement for the NCCC, and I'm going to turn it over to Christine Pecci for the last presentation.
Hi, everybody. So I also know that we are running longer than we intended, and people have to get to clinic. So no one's offended if you need to leave, and we appreciate you being here. So I'm one of the perinatal consultants, along with 3 others, Puja Matal, who was a previous faculty member here, Leila Pollack, who was a resident here and did the HIV track and is currently attending on our inpatient service, and also Deb Cohen, who's an OBGYN in our department here and has been at the hotline for the longest time. So I came to UCSF in 2013 with a strong background in obstetrics, but actually not a strong educational background in HIV. I now, as one of the perinatal clinicians, know this guideline back and forth, this one here, next slide, and also will point out that, it gets updated at least annually. So there's a lot of information there to keep up with. The next slide. But I did my training in that, I don't have a pointer, but you see that hump there? That is when I did my training. And then I was at a place where the patients with HIV were being taken care of by a specialty clinic. So I did not learn a lot of what like my colleagues know, like Leila and the other people on our team. And I was calling when I received a patient who was living with HIV and in labor and delivery. I was the one calling the hotline. And this slide stops at 2010, but I couldn't find an updated slide because it's actually not that interesting. See, it goes down to close to 0, and then it just like keeps on going. So that's good news. But that's just to say that I rely on our team. Betty spoke about how we all consult with each other, and I could not do my job if it weren't for the other people on the team and the consultants that we have. Next slide. So the good news is that we are close to zero in terms of perinatal acquired infections. And we do help callers, with the information that's in the clinical guidelines. And it's a 500-page document, and it gets updated every year. And so if you're a clinician, you don't see much HIV, and you have a patient who's laboring, you're just trying to figure out what medications to do a C-section. If you go, what can you do? The pediatricians try and prepare for the medications they want to give the baby. We're there to help support them. And sometimes just to help them, tell them that what they know is actually right, and that those recommendations haven't changed. But more and more, we do consultations that are like in the gray zone, which is really the zone where we don't have information. We don't know really what the right answer is because we have no data. Next page and next slide. And so some of these discussions I won't go through, just you can sort of look at them. But when we have these discussions, it is around the areas of like, well, what do we do when we haven't done that study yet? Next slide. And we want to recognize too, is that, this is from 2007. So I didn't find something more current, but I am pretty certain that we still continue to have quite a bit of bias around patients living with HIV and what we think or not think they should be doing with their reproductive plans. Here it's 14% of Americans believe that women living with HIV should be having children. You can see how that compares with other diseases. So we have this bias that persists, and we don't necessarily as a medical community respect the agency of all patients to have their reproductive rights respected. Next slide. And most recently, we've been having discussions about HIV and breastfeeding, and we are currently now really weighing, so the official recommendation is that we not breastfeed, at least in the United States, because of a very small risk of transmission. But we are now weighing the benefits of breastfeeding versus the very, very low, possibly zero risk of transmission to the infant. And Judy Levison, one of our sort of third tier perinatal consultants, is really a leader in the discussion about this. And, when there is no data, we encourage our callers not to put up, you can see some of these, do I need to call, this feels like child abuse. Do we need to notify CPS? So it may be a natural reaction to put up a barrier when we have a patient who doesn't want to follow the guideline, right? Our box guideline. But instead, we encourage our callers to try and lean into the patient and have a discussion and really respect the fact that though we are the experts of the clinical guideline, they are the experts of their own life and their own experiences and what they're going to do when they leave the hospital. So we really try to reinforce that as part of our consultants. We check each other as well. And one of the initiatives we've had recently over the last year is that Karen Scott, who's at UCSF, has developed this OB and racism series. And all of us as consultants have time to review that. And we've also provided that to us, others in the community as well, who take care of patients living with HIV. Next slide. And the last slide, I'm just the last thing I'm going to leave us with is, as in all things in medicine, we're doing a great job with getting to zero. And yet the patients, the people who are still being diagnosed with perinatal HIV, if you break it out by race, we can see that we are lagging behind with our Black and African American patients. And so there, we have work to do, and we need to get systems in place so that we are making sure that we are doing everything we can for all of our patients, regardless of their race. So next slide. I know we're really 12:54, but thank you so much for your attention, and thank you for staying a little late with us. For those of you who are still on, and I don't know if we really can have time for a few questions, but I'm going to hand it over to Margot.
I want to thank all of our phenomenal presenters today, not just for the work that you've done this afternoon, but really for the work that you've been doing for the past 35 years on behalf of patients and clinicians and trainees. You're making a remarkable difference. I think we have maybe time for one one question, which is from Josh Connor, which I will just read out and ask. Josh thanks you for an excellent presentation. And he said, thanks to Betty for highlighting the distinct need of incarcerated patients and clinicians working with incarcerated patients through the collaboration with the Federal Bureau of Prisons. Has the NCCC had any collaboration with California State prisons or any other systems? And I think this is the only question we're really going to have time for. So if you want to stop sharing slides, maybe one person could answer. Thanks.
Sure. Thanks, Margot. Thanks, Josh. I can take this. So no formal collaboration, but we definitely have gotten calls from CDCR. So we would be happy to explore if there's any interest in developing anything more from correctional settings.
Can I just, sorry, can I just add that family medicine used to have a collaboration with San Quentin Hospital. And I don't know what happened to that, but I actually, based on that collaboration with family medicine, myself and some other clinicians actually worked at San Quentin Prison for a few years until that collaboration went away.
So Josh, we're counting on you and all of our other grads and colleagues and allies to help us build not just that collaboration, but others. This is a great opportunity. I really want to thank our fantastic presenters today and then hand the session back to them for just one final word of wisdom before we sign off. And thank you to everyone attending today. If you joined late and you missed part of the session, remember that you can watch the entire session or any other one on the Family and Community Medicine at UCSF website and department website. And please fill out a session evaluation. Thank you to our presenters, and please leave us with one thought or word of wisdom or words of wisdom that you'd like to share with us. Thanks.
Well, firstly, we just want to thank the department, of course, and thank you, Margot, for having us. We've really appreciated having this time today. I think the words of wisdom that we have is, I think we recognize our most important resource is the entirety of our team that really makes all the wheels go round. And ultimately, our ability to serve everyone in the community is because I think it comes from our compassion, our heart, our desire to really actually move the needle towards health equity. And so certainly if there's opportunities or ways we can support other projects or research that's happening within the department, we're really thrilled and invite those opportunities, including even observerships, if you're interested in hearing some of our fascinating calls that we get through the lines. Thank you again for having us. And yes, you're all welcome to call us if you have questions.
Thank you. And thank you to all of our presenters and audience. Thanks. Have a good day.
Thank you.